this densely brunescent cataract, we're making a small 0.5 millimeter paracentesis. We've used trypan to see the surface of the lens so that we can do a proper capsulorhexis, and now we're assuring that the lens is mobile. I'm using burst mode with a Rosen splitter, and my goal is to do circumferential disassembly of this lens. So I'm not even looking to be able to get down into a full crack, but rather just open it like a clamshell. So you can see here we've used not even 2 seconds of phaco, because the goal is to go ch-ch to get in with burst mode, and then to just use our second-hand instrument to begin to make these small radial chops that do not go deep, but will allow us to open it to access the central part of the lens, the nucleus. The thing is that the anatomy of the lens remains the same, as even though it becomes extremely dense. So though the endonucleus cannot be delineated, hydrodelineated any longer, it is still there. So our goal is to open this up with these tiny little cracks, using ultrasound only as a means of gaining purchase, and now finally starting to debulk the endonucleus. You see here, and this is sped up to a little over 2 times, 2.25. You'll see here that I'm beginning to gain purchase on the very densest portion, the endonucleus, and I'm forcing the epinuclear shell to stay in position, never wanting to crack through to the leathery interdigitated fibers below. And that way it remains like a shoe tree in the shoe, protecting the bare posterior capsule, which won't have any cortical remnants to protect it, and keeping the bag expanded in case of poor zonular integrity. Little by little, we're allowing the center part of the nucleus to be brought out. And if you could hear this, you just hear ch-ch, ch-ch. So this is why we remain at very low phaco times. We're doing this under a sealing of viscoelastic, of dispersive viscoelastic, and of course we must always establish flow in foot position 2 before we go into foot position 3. We're able to now begin to thin it in a circumferential manner, 360 degrees, so that we're not concerned about going all the way down to the bottom. And you'll see that we have our parameters rather aggressive at 400 to 450 and 40 to 45 of flow. We've got the bottle up at 110, and I'm just using my second-hand instrument rather aggressively, so that the phaco tip pretty much stays within the safe zone, and really so does the second-hand instrument. We virtually never have to go out beyond the capsulorhexis edge, and all of our ultrasound is done pretty much at the iris plane or below in the bag, so that we're really disassembling this in an endonuclear fashion. We're just now beginning to get to the nucleified epinucleus, and you can see we've used a cross-action vertical chop throughout, and now we're going to be very mindful of the fact that the bag is now exposed. And so after I get things sufficiently thinned so that there are no large pieces to bring into the front of the eye, making this sweeping motion with the chopper from time to time, now I'm going to lower the parameters once I decide that the capsule is vulnerable. You'll see us go to about 300 or 350 and 30 or 35, so things happen a little more slowly. Here's where that's taking place. Now, I could change to torsional at this point, but I've preferred longitudinal throughout because I want that setting appropriate, and you see how we're protecting the bag from surge with the second-hand instrument. The power has been set at 80 to 90 because of the density of this lens, so it's as we go down in foot position 3, we get a closer and closer burst interval. So it's as we go down, and that's what's linear, not the power. Therefore, we don't ever clog. Now we want to be sure these eyes are really clean, and I'll clean the anterior capsule flap as well as any cortex that's left, and you can see we have a nice clear cornea, as we always do with this technique. I've decided, because this patient is mentally handicapped and requires general anesthesia, to make a primary posterior capsular opening. So I've just used a 30 gauge bevel up syringe to graze the posterior capsule and make a hole, and now we're using cohesive viscoelastic to form Berger's space and push the intact anterior hyaloid away. Since we never know whether Berger's space is real or potential, it's necessary to do that. We want to make sure our vision is very clear on high power with a nice clear cornea. You saw a drop on the cornea. A little more of a guiding force for this 5 micron thick membrane, and we're trying to copy just inside of our measured 5 millimeter capsulorhexis, which we measured with a caliper when we made it, and we're sure that we had something as a backdoor option to be able to capture through the anterior rhexis if necessary. So then we've managed to do a continuous posterior capsulorhexis, and we do use OVD, which I've edited out. I will have edited out, but I've decided it's a little small. I don't want to stress it. I want it to be nice and symmetrical. So I have enough control that I can even use a Vanus or an intraocular scissor and enlarge this just a little bit to make it nice and symmetric. We have a nice continuous circular opening in this posterior capsule. We've blown up the spare tire with OVD so that we can definitely place this 3-piece lens guiding the leading haptic nicely into the fornix of the bag and not below the bag into Berger's space, where we certainly wouldn't want it. And now we're going to fully place the optic into the capsular bag with the haptics in the bag. Now we're going to capture the optic through the posterior rhexis into Berger's space, and so you can just barely see how we've got that cat eye appearance of the posterior capsule from